Thank you very much, Mr. Chairman, and thank you, Director Fowler, for testifying before the subcommittee today. I'm grateful for the opportunity to have a discussion with you on barriers to increasing the presence of value-based care in our healthcare system in the form of attractive payment models that benefit both patients and their physicians. Our healthcare system, unfortunately, is suspect to waste and poor health outcomes, and growing complexities in our system have invariably led to fragmented, uncoordinated, and costly care. Rather than reimburse care based on quantity, that is, the number of patients seen, test orders, or procedures done, value-based care shifts, or is hoping to shift the focus to rewarding positive health outcomes that are based off quality. I don't doubt your commitment and your passion for this issue. However, one of the many challenges with existing accountable care organizations, ACO models, is that they often fail to produce real savings to the Medicare program. And the value add for physicians to invest in value-based arrangements, and I don't mean invest only financially, I also mean invest their time and their effort, are overburdensome or lacking. Additionally, I hear from specialists that they are often not heard by CMMI when it comes to creating new payment models. And the vast majority of CMMIs or the center's models have not saved money, with several on pace to lose billions of dollars. You have mentioned several times about working with hospitals in regards to specialists in a few of your responses. But I would hope, and I highly encourage you to engage the specialist community directly rather than work through consolidated entities. One of the things this committee has worked on is the consolidation that has occurred. So I would recommend reaching out to them. Do you believe that there are enough alternative payment models or APMs approved by the center for all physician practices to participate, particularly specialty practices? And in other words, is there currently an environment in which all practices are able to move to value-based care models?
Well, I think there's probably room for more engagement with specialists, and that's why we outlined a specialty care strategy a couple of years ago to identify ways of engaging specialists more in not just accountable care, but also in value-based care more broadly. So it's one of our goals and something we're focused on for the future.
Do you think, and I think you mentioned this peripherally, Physician-Focused Payment Model Technical Advisory Committee, or PTAC, has an important role to play in the creation of APMs?
We agree with that, and we've had excellent engagement with PTAC and consider them an important partner for our work that's informed a lot of our direction. So
do you think that there are more opportunities to engage with physicians, especially specialists, to engage in the APM model and or their specialty organizations? Because I understand your comments, but the reality I have from physicians with whom I work with and engage is that there's non-engagement with them.
I would welcome the opportunity to talk to them if you want to send them our way.
Okay. One of the focuses of the center under this administration has been to help reduce the challenges for various populations, including those in rural areas. One of the diseases which disproportionately hits these populations is kidney disease, which I think Dr. Bouchon mentioned. CMS has attempted to address some of these disparity issues through a number of actions, such as the Comprehensive Kidney Care Choices model, which has received bipartisan congressional support and has seen significant uptake and I think also success. However, recent decisions made by CMS to retroactively adjust the benchmark for calendar years 2022 and 2023 has put this successful model at risk financially, as financially providers will not be able to sustain the level of risk they're being asked to bear, despite being able to successfully manage care and lower spending for these patients. While I applaud the center's recognition of the issue and recently announced changes to limit the impact of the retrospective trend adjustment to the benchmark beginning in 2024, still nothing's been done for 2022 or 2023. After you announced the changes in April for 2024 with no relief, did any participants withdraw from the kidney model?
Thank you for that question. And if I might just step back a moment to talk about the retrospective trend adjustment, that's part of our models and the way that we design models. And it's there to protect both the trust fund and participants if it turns out that the projections that go into our benchmarks change in any one direction or another. There was a lot of uncertainty coming out of the pandemic and the public health emergency and in making some of those projections. We have worked to address, as you mentioned, the RTA going forward from 2024 on through corridors. We, as a general rule, tend not to make
So
retrospective.
if I may, and if you'll indulge me, Dr. Burgess as chair, my question was, did any participants withdraw from the kidney model? And if yes, how many?
We started the year with 100 participants, and after the period to drop out at the end of April, we're at 80 participants currently.
So 20 dropped out. So I think that means we need to reconsider the retroactive for 2022 and 2023. Thank you. I yield back.
Gentlelady